Close our eyes. Heavenly Father, we ask for your guidance and wisdom as we gather today. May our hearts be open to listen and our minds be clear to communicate. Fill us with your grace, Lord God, and continue to remind us that all that we do for the Cancer Society and all that we accomplish is for the service of humanity. In your name, we pray. Amen.
Amen. Thank you, Aaron. Welcome, everyone. Good to see so many people on this evening. I'm sure we are all anticipating a very nice presentation, lots of information. And we'll get to our speaker in a minute. But before we do that, is anyone celebrating any birthdays, anniversaries, milestones that they would like to share? And we can help you to celebrate. If you are, just either open your mic and let us know who you are and what you're celebrating, or you can put it in the chat. Surely somebody's celebrating something out there. Don't be shy. We love to celebrate. Don't we, Aaron?
Yes, absolutely.
Okay, well, throughout the course of the evening, if anyone wants to put something in the chat, we will come back to that at some point, and we will carry on the celebration later on throughout the evening. Right now, I would like to ask our Assistant Administrator, Ms. Patrice Moxey, to join us with any upcoming announcements and events happening this month at the Cancer Society and our branches. Over to you, Patrice. Patrice, are you there? Aaron, can you?
Hello, everyone.
Oh, hi, Patrice.
Hi.
Go ahead.
Okay. We just want to bring to your attention the upcoming events for March happening this month at the Cancer Society. We're having on Saturday, the 14th of March, they're having the PAP and PSA clinic in Kemp Space, South Andros. We'll also be having an annual general meeting that is upcoming and open to the general public on Saturday, March 21st. The annual general meeting starts at 9 a.m. through to 12 p.m. So all are welcome. And last but not least, we have an in-person support group meeting on March 12th at the Cancer Society for all type cancers, anyone impacted by cancer, that the person that is actually suffering from cancer or is in remission, their families are welcome, as well as their caregivers. So we hope to see you at the annual general meeting, if you can make it, or the in-person support group, just to support those who are affected by cancer. Thank you.
Thank you, Patrice. Just to, I guess, reiterate on the AGM meeting on that weekend, this Saturday, we'd really like to see any of you interested in hearing what's been going on with the Cancer Society, what we've done in the past year, what are our plans for the future, our financial report. All of that will be put out in the public. So please come out and join us on, what was the date? Saturday,
Saturday, March 21st.
March 21st.
Right here
Love
at
to
the
have you
Cancer
all.
Society.
Right, at our Caring Center. Okay, so now we will move on, get right into our speaker without further delay. And our speaker tonight is Dr. Beverton Moxey, who is a highly respected gastroenterologist and internal medicine physician. He possesses a deep understanding of medical care delivery and healthcare management and these attributes serve him well in the clinical leadership roles that he holds. Dr. Moxey is the Vice President of Clinical Services at Doctors Hospital Health System, and in this capacity, he provides clinical oversight for all inpatient services. He has a robust private practice at GastroMed Associates, which is located at First Terrace at Collins Avenue, that encompasses his specialties of gastroenterology and internal medicine services. Dr. Moxey is the Medical Director of Family Guardian in Bahama Health and is a consultant physician at Princess Margaret Hospital. Dr. Moxey completed his internal medicine residency at the University of Virginia, Roanoke, where he served as chief medical resident, and his gastroenterology fellowship training at Cleveland Clinic in Florida. His professional affiliations include Fellow, American College of Physicians, American College of Gastroenterology, American Society of Gastrointestinal Endoscopy, Association of West Indian Gastroenterologists, and Medical Association of the Bahamas. Dr. Moxey is a life member of Omega Psi Phi fraternity and a member of the Delta Lambda Boule of the Sigma Pi Phi fraternity. He is an avid junkaneur and enjoys boating. Dr. Moxey is married to S. Roselle Moxey, and together they have 3 children, Seth, S. Regan Olivia, and Sierra. So let us all give a warm welcome to Dr. Beverton Moxey. And Dr. Moxey, if you're ready, we are ready.
I am ready. Good evening, everyone.
Good
I'm going to
evening.
go ahead and begin sharing my screen. Let's see.
Quick story, and this is a true one. I was at Cleveland Clinic a few years ago, something not colon related or anything, but the doctor that I saw, when she realized that I was from the Bahamas, she asked if I knew Dr. Moxey. And at that time, I didn't know him, but I had heard of him. And she said, "Oh, he did his fellowship here with us. He's a really great doctor." And I endorsed that message.
Thank you very much. I appreciate that endorsement. All right. Now, without further ado, let me go ahead and get started. Again, welcome everyone to the Cancer Society's lecture. March is special for us. It's Colon Cancer Month. And so it's during this month that we really want to raise awareness about colon cancer and the importance of colon cancer screening. So this presentation this evening will focus on just that. And I'll be sure, happy to take any questions afterwards that you may have. Right. So let's start by trying to understand what is colorectal cancer. So first and foremost, colorectal cancer is the 3rd leading cause of cancer in the Bahamas, behind prostate cancer in men and breast cancer in women. It affects both men and women equally, and it is more preventable. This is the key here. It is more preventable than breast and prostate cancer. And I'll show you why as we go on later in the talk. So colorectal cancer can largely be prevented by detection and removal of adenomatous polyps. So the way that I explain this to patients is think of polyps as little pimples on the skin that are on the inside of the colon. And these polyps, some of them have the potential to develop into cancers and some won't. But there's no way for us to determine which ones will just by looking at it. So when we do a colonoscopy on a patient, all the polyps that we see. Survival is significantly better when colorectal cancer is diagnosed while it's still localized. And we'll show some information as we move on about the different stages and how colon cancer progresses and how polyps progress. So in terms of understanding colorectal cancer and why you can prevent it with screening. So prostate cancer, you can't prevent with screening. You can detect it by doing PSAs, by doing digital rectal exams, by doing MRIs of the prostate, but you can't prevent it. Similarly with breast cancer. Breast cancer, when we find it, it's already established itself in a mammogram or an ultrasound. However, colorectal cancer starts out as a polyp, and that polyp is what's going to grow into a cancer. And that is why this is the cancer that you can prevent, as opposed to the others, you just detect them. So colon cancer affects, or colorectal cancer affects the large bowel and the rectum. And this happens when these cells form in the inner lining of the colon or the rectum. Most colon and rectal cancers originate from benign wart-like growths, which I described earlier as pimples on the inner lining of the colon. And those are called polyps. So I want to focus your attention to the diagram on the right, and you can see this is a schematic of what the colon looks like on the inside. And you see there are two things that are protruding, and then there's a large version to the top of it, which really shows you what a polyp looks like. This is what we see when we're doing exams. So some colon polyps can just sit just flat onto the surface or to the lining of the colon, and some of them are on a long stalk, where it looks almost like, think of, I want you to visualize a mushroom with a stalk, where the stalk of it, and then you have the head of the mushroom being the polyp. And so some polyps are on a stalk, and some polyps are actually flat. The interesting thing about this is that polyps actually, it takes a long time for a polyp to develop into a cancer. We're talking somewhere between 7 to 10 years. And so that's why it's important that when you talk to your physician and they tell you, well, doc, how often do I need to have this colonoscopy done? And so they would give you the scenarios that if they find polyps, they're going to want to do it in 5 years or sooner, depending on the type and the amount of polyps. Or if it's completely negative, they may tell you come back in 7 or 10 years. It all depends on your risk factors. And this is purely for people that are not symptomatic. This is just somebody that's coming in to get a colonoscopy because they're due for screening, but they have absolutely no symptoms. Why is colorectal cancer screening important? Well, it's important because it allows us to remove those polyps or those wart-like growths that I just showed you before they can actually develop into cancer. Remember, this is a type of cancer that is totally preventable. And that's really the take-home message. And I hope, everyone, it resonates with all that's listening tonight. So where does it start? So if you look at the diagram at the bottom, you see where it says hyperproliferation. So you see a little small bump, and then it gets bigger, and then it gets larger. And so that's kind of like what it looks like. It's just something, think of like a pimple that's just sitting on the lining. And then that pimple then starts to take form where it changes. And the word that you see that says dysplasia, it means that those cells are now turning from normal cells to now abnormal or precancerous cells. And then that further develops into adenocarcinoma, and then it further develops into a cancer that can spread. So what is a polyp? A polyp is a small clump of cells on the lining of the colon. Most of them are harmless, but some can develop into colorectal cancer. Not all polyps will turn into cancer, but all cancers start as polyps. Let me repeat that. Not all polyps turn into cancer, but all cancers start as polyps. So if you've had a colonoscopy before and the physician has told you that they've identified polyps, there's nothing to fear because that's common. We see polyps commonly in patients when we do colonoscopies. And not all of these polyps are going to be cancerous. But we must remember that all cancers start as polyps. And this is why it's important that the physician takes a careful look as they're going in and as they're coming back out, because you want to make sure that you remove those polyps, all of them at the time of the test. Because colon polyps do not usually cause symptoms, it is important to have this regular colorectal cancer screening, such as a colonoscopy, which gives you a direct visual look at the inside of the colon. So these are just examples of some of the things that we see. You know, you can see that polyps come in all shapes and sizes. When you look to the top left, you see a little bump with a short stalk. To the top right, there's something that's a little bit more bulkier, multilobulated. If you look at the bottom left, it's very flat, that little red, orangey protuberance that you see there, that's a very flat, small polyp. And then when you look further to the bottom right, you see something that's a little bit more spread out in a carpet-like fashion. And so these ones are, you know, very easy to see. The one on the bottom left is a little bit more harder to decipher. And so certainly that comes with time, it comes with training. The more you do, the more comfortable you become with looking at what the normal lining looks like and what an abnormal lining looks like. And this, ladies and gentlemen, is exactly why when the physician is having the conversation with you as it relates to bowel preparation, my bowel preparation, and ensuring that you do it adequately and that you make sure that you drink all of that laxative to clean up is so important. Because if you don't, you see that polyp that's on the bottom left, that can be missed if it's coated with stool. And so you want to make sure that you get a very good exam. And so, you know, following the instructions in terms of diet restrictions, as well as drinking the preparation is extremely important to ensure that we have good visualization of your colon during the colonoscopy exam. So this schematic here just shows person kind of standing and how your colon is actually situated in your body. And so when I'm describing what I'm going to do when a patient comes in for a consultation, I normally say your colon is like an upside down U. It goes up, it goes across, it goes down. And I describe it as almost like an accordion, like driving through a tunnel. And in its natural state, it's like a cooked noodle. So if you were to cook a macaroni noodle, it's going to be very flat on itself. However, when you, if you don't cook it, just taking it right out of the box, it's hard, and you can actually see straight through from one end to end. And so in its natural state, your colon is like a cooked noodle. It's very flat, it's very moist, it's kind of sitting flat down. And so as we do the colonoscopy, a part of being able to adequately see the inside of the colon is us introducing air that actually helps to distend that colon so that we can actually take a careful look and as we're driving through that tunnel. And so on the inside, it looks like an accordion, or if you think of like a phone cord with all of the different folds. And so you want to be very careful looking in the front and behind all of those folds as you move along. And then you see to the right of that schematic, you see where they have this lesion that's kind of protruding into that lumen, into the center, into the you know, of the bowel, and that's an evidence of a colon cancer. So what are some of the stages? Patients always ask about stage. You know, this seems to be, you know, something that people are, you know, obviously very concerned about if they're told that they have a biopsy that's now come back as cancerous. And so staging really requires a couple of things. It's not something that you can tell just after doing a colonoscopy exam in and of itself, because staging requires us to know if the lymph nodes are involved. It requires us to know if there's spread of the cancer to any distant organ, and colon cancer commonly likes to go to the liver, and sometimes it can go to the lung. And so, you know, stage 0 would be, of course, the earliest stage where it's a very tiny lesion. It's really just confined to the bowel lining. Similarly, same concept in stage 1. In stage 2 to 3, it can involve deeper muscle layers. And when you get to the 3rd stage, you're talking about now having lymph node involvement. So the cancer is now spread through the lining, through the muscle, and is actually now in the lymph nodes. And so you can see when you look at the picture for stage 3, and where that the green schematic that's on the side of the bowel, you see that looks like it's mixed with green and pink. So that's showing you that that cancer is kind of moved into the lymph nodes. The green represents the lymph nodes. If you look above in stage 0, stage 1, and stage 2, you can see clearly that it just looks, the lymph nodes look entirely green. And then when you get to stage 4, this is not only just spread into the lymph nodes, but it's now also traveled to the liver, and it's traveled to the lung. And the way that we are able to determine that is really by doing a CAT scan. So if we do a colonoscopy, if I do a colonoscopy on a patient and I see that there is a large lesion in the colon that is very suggestive of a colon cancer, the next thing that I'm going to order is a CAT scan of the abdomen and possibly a CAT scan of the chest. And the reason why we do that is we want to take a look at the liver, and we want to take a look at the lung, and we want to see if there's any evidence of spread to any of those other organs. The second thing that we're going to do is we're going to refer you to a surgeon, to a surgical oncologist or to a general surgeon, who then now, once they get the biopsies back, will then make a decision about how do they remove, how do they excise this cancer, what portion of your colon are they going to take out. And when that surgeon does that procedure, they're also going to look for the lymph nodes that are nearby that bowel. And they're going to remove some of those lymph nodes to test them to see if there's any evidence of spread. And that's how we put all of that together. We put what we find on the colonoscopy, we put what the surgeon finds at the time of the surgery, and what findings we see on any imaging, which would be the CAT scan of your abdomen and the CAT scan of your chest, to determine what the patient's overall stage would be. And that directs treatment, what's going to be the next step.
Finally, there's good news tonight about a high school basketball team organizing a surprise.
If somebody has their mic open. Okay. Understanding who's at risk for colorectal cancer. So, as indicated earlier, colorectal cancer affects both men and women. It's a 1 in 23 lifetime risk of colorectal cancer in men and 1 in 25 lifetime risk of colorectal cancer in women. So that means that, as you see, both men and women are essentially equally affected. So this is one of the cancers that kind of affects men and women similarly, and why, as a part of your routine preventative health, at the age of 45, your physician is going to be recommending that some form of screening takes place for colon cancer. So what are some of the factors that increase your risk? If you have a family history of colon cancer, so family history would be, especially if it's in a first-degree relative. And what do we mean by first-degree relative? We mean if you have a history of colon cancer in either of your parents or any sibling, and that's considered a first-degree relative. That puts you at a high risk. A family history of having adenomas, having significant amount of colon polyps. Persons who smoke tobacco, cigarette smoking, is a risk factor for colon cancer. Being obese, gallbladder removal, physical inactivity, cancers of the uterus or ovaries before age 50, patients who have ulcerative colitis or Crohn's disease, patients who are of the African race. Black people are more commonly affected by colon cancer compared to other races. So what are some of the factors that decrease your risk? Regular use of aspirin. So if you take an aspirin a day, a low dose aspirin a day, that is chemopreventative. Regular intake of calcium and folate. That can happen from your diet, just the foods and stuff that you're eating. If you exercise and you maintain a good body weight. Want to just stress that none of these lifestyle factors is as important, though, as colon cancer screening. Okay. What are some of the symptoms and signs of colorectal cancer? So most early colorectal cancers produce absolutely no symptoms. You can actually have something going on and you're not even aware. And only until when it gets to the point where it's either causing a blockage or you're having significant bleeding. And that is why screening is very important and why you should have some form of screening as a part of your preventative health maintenance. Some possible symptoms that certainly would warrant a visit to your doctor and to a gastroenterologist would be if you note a change in your bowel habits. So for instance, if you're accustomed to going to the bathroom every day and having a bowel movement, and now you're going to the bathroom every 4 or 5 days. If you are accustomed to, seeing your stools formed and of a certain size, now they're coming out pencil thin or in small pieces. If you notice blood in the stool for any reason, just blood in the stool, that should be a worrisome symptom. If you have unexplained abdominal pain or unexplained anemia, and especially in a male, I always tell my male patients, I said, listen, there's absolutely no reason that a man should be anemic because we don't have a menstrual cycle. And so if we're losing blood, then we have to figure out why that blood is being lost. Either one, we're losing it from our gastrointestinal tract, meaning that you're either vomiting it up or you're pooping it out, or your bone marrow is not adequately making the blood. And so anytime you see a male with anemia, that requires an evaluation. That's not something that you should really sit on. Also, in terms of the females, if you know what your baseline counts are, and you see that there's a change in that's unexplained. So that also requires your physician to dig deeper and to refer you to have that evaluated. So should I wait until I get symptoms to get checked for colorectal cancer? I'm sure everybody can answer this question. It's an absolute no. So half of those who are diagnosed after symptoms develop will die from colorectal cancer. And remember, we said that most people don't know that they actually have cancer, especially in the early stages. They may be totally asymptomatic, and that's why screening is so important. What should I do if I don't have any symptoms of colorectal cancer? So the answer is get screened. Screening means getting checked even when you have no symptoms. Screening for colorectal cancer is much more effective than screening for breast cancer or prostate cancer. They all are important. I don't want you to leave from here thinking that, that breast and colon cancer evaluation and doing your tests, your mammograms, ultrasounds, prostate checks, etc., are not important. But of course, we're talking about colon cancer awareness here, but it's very important. It's very effective in terms of ensuring that we prevent you from developing cancer. So let's talk about what are some of the screening options. So we have screening options that would be considered one step, and those that would be considered two-step. So according to the latest guidelines by the American College of Gastroenterology in 2021, they explain the difference between one-step and two-step tests. And so, patients would always ask, well, what's the best test or what's the best screening? Well, the right answer would be the best screening test is the one that gets done. But there's some that, obviously have higher yield in terms of determining cancer and certainly being able to remove polyps. And so as we move along, you'll see what I'm talking about as we talk about the one-step and two-step screening tests. So a one-step screening test is a colonoscopy. It is the recommended go-to gold standard for colon cancer screening. And the reason why it is because it allows us to visualize and which means to detect polyps and to remove them at the same time. All right. And it's the most powerful colon cancer prevention tool in clinical medicine today. It's the, We talked about this already, so we can move on. It's the only one that allows both identification and removal of polyps, which is called a polypectomy. What is required? Bowel preparation is required, and that is critical. You know, when I'm having my consultations, I usually tell patients, you know, the exam is only going to be as good as the prep. If we are going to do a colonoscopy on you and go in there and the colon is still full with stool, one, we can't see where we're going. So it's like driving through a blizzard storm. And so therefore you're going to abort the procedure, because otherwise you cause damage to the lining of the bowel. And then it also, you can't see anything. So you can't even at the end of the examination tell the patient that I can clear you to come back to see me in 5 years, 7 years, or 10 years, because you were not able to adequately visualize the lining of the colon. This procedure is done with sedation. It also requires you to go on a special diet the day before. And that diet is a clear liquid diet. And so when you would visit the gastroenterologist's office, they're going to give you a handout that explains what a clear liquid diet is, but that's consists of things like apple juice, white grape juice, clear broth. You can have coconut and water without the coconut pulp, of course. You can have coffee or tea, but you can't add any cream or creamer to it. You could add sugar, you can add lemon or lime to the tea if you desire, and you can have water. And pretty much that's what you take for the entire day before your procedure. So you're on a clear liquid fast, and that's for breakfast, lunch, and dinner. Let's move on. So this is a polyp that's kind of protruding into the lumen. So you can see here what I described to you earlier. This is exactly what we see as we're going down. It's like driving through a tunnel, and you have all of those folds. So you're looking front and behind those folds, because polyps tend to hide. Not all of them stick out like this. Some of them actually lie flat. You see the metal wire that's kind of protruding into that bowel lumen as well. That's what we call a snare. So we have different devices that we use to remove polyps. I describe this as a lasso. Think of it, we put it around the actual polyp, go to the base of it, tighten it, we burn, cauterize, and cut. And then we are able to extract that polyp from the lumen, and we send it to the lab to be tested and looked at under the microscope. The picture to the right is what the colonoscope looks like. That's what we use. It's a long, flexible tube. At the tip of it is a camera and a light source. And so as we're going in, we have direct visualization of the colon. And you see it's inserted through the bottom. It goes up, it goes across, and it goes down, all the way to where you see the sign that says small intestine. That's when we get to the end of the colon. And then after we've gone in, we come back out in a similar fashion, very slowly, almost doing what I call a matrix move. So you're looking around the walls of the colon very carefully, very slowly. We have, according to our guidelines, we have what we call withdrawal times. Withdrawal should not be any quicker than 8 minutes. So you should be taking your time as you're coming back, because you want to make sure that you see in between front and back of all of these folds of the colon very carefully, because you can miss lesions if you don't. This is the position that you kind of lay. So patients ask, well, you know, how am I positioned? So you lay on your side, and the gastroenterologist is standing behind you. You can see how that the actual colonoscope is going through the colon, and then we're looking at a monitor, which is the camera that's at the tip of that scope is connected to like a TV screen that we're watching as we're looking. And so you're resting comfortably, not feeling any discomfort. You know, it takes us maybe about 30 minutes to do, and then that's going in and coming back out, and then we keep you in a recovery area for about an hour afterwards, just so that, you know, the sedation can wear off and you can safely go home. Not drive home. You need to have a designated driver, but you can go home and feel comfortable that you're doing fine post-procedure. So what are some of the two-step screening tests? So two-step screening tests are stool-based tests. So some of you may have gone to your physicians, or your NHI physicians or your private physicians, and they may have given you, asked you to submit a stool sample. And that stool sample could be in the form of a FIT test, which is a fecal immunohistochemical test, or which is available locally, or a multi-target stool DNA test, which is not available locally. But I'm sure you guys would have heard of that on the TV, and that multi-target stool DNA test is called Cologuard. So the FIT test, it detects hidden blood in the stool. If your physician elects to do this form of screening for you, it should be done on an annual basis. And if the test is positive, you must automatically be referred to have a colonoscopy. And that is why it's called a two-step test. So the first test is the stool test. And if it's positive, now you have to do a colonoscopy because that's the gold standard. And that allows us to see why did they detect blood in the stool. The multi-target stool DNA test, similarly, it looks for abnormal DNA, which is associated with colon cancer or precancerous polyps. This test is more sensitive than a FIT. If it's negative, this one is repeat in terms of screening in 3 years as opposed to yearly, which we do for the FIT test. And again, if it's positive, you must absolutely be referred for a colonoscopy. And that is why, again, this is also a two-step test. So you start out with stool. If it's positive, then you refer to the gold standard test, which is a colonoscopy. And so oftentimes patients just want to forego this and say, let me just do a colonoscopy one time. So this is what a FIT test looks like. This, again, like as I said, is available locally. And then this is Cologuard. You may have heard this advertised on TV, but it's not available locally. So who does these tests? Either one, it could be, obviously there's a cost factor. So doing the stool tests are much more cost effective. And especially for patients that may not have insurance or access to cash, that they would be able to afford to do a colonoscopy, doing a stool test will be much more economical for them. Other type testing that could be recommended would be doing a CT colonography or a capsule endoscopy. However, the limitations of those tests are exactly that. They're also considered two-step tests. Why? Because if you do a CAT scan, first of all, it doesn't see polyps below a certain size, below 1 centimeter, and most polyps are below a centimeter. And then two, if you do see a mass in the colon, you have to now refer that patient to getting a colonoscopy, because doing a CAT scan, which is like an X-ray test, it does not allow you to perform any intervention. Similarly with a colon capsule, which is where you swallow a pill, it moves through your colon, through your bowel, from the mouth, through the small intestine, large intestine. It takes pictures along the way. It just says, well, I saw something in here, but now you can't do anything about it. You now go and get a colonoscopy. This is a CT colonography. As I said, it's an X-ray. It's not the most comfortable procedure, like patients that I know that get it done, because they put a tube into the bottom and then they distend your colon with air, so they fill you up with air, so you're kind of blown up, and that's important because you want to be able to see the lining and get a good visualization of the colon. Sometimes this may be, a way of screening for a patient that may also be. We use this, as gastroenterologists as well. You may have a patient who may be a high-risk patient, someone who, if you're not going to do the stool test, somebody who essentially has significant medical problems, may have be a high risk for anesthesia if they have severe lung disease. And so certainly giving them sedation may be problematic or a little bit more challenging, that requires them to actually go on a ventilator. And so if you have a patient who needs to be screened, like they actually have no symptoms, we're not gonna, in most instances, say, hey, let me have you go into the theater, connect you to a ventilator because you have severe lung disease so that I can do a screening test. If you have symptoms of something that's worrisome, then yes, we probably may take that leap. The other reasons why we would do a CT screen would be if we did a colonoscopy on you and we could not get all the way to the end. Sometimes there are persons who have what we call very redundant, so their colon length is much longer than usual, and so you run out of scope. So the flexible tube that we use, it's not long enough to get all the way to the end. And so we may use this particular procedure to allow us to see the remaining part of the colon that we were not able to visualize. So when should you start to get screened? So it's recommended now that individuals should be screened between the ages of 45 to 75. Screening beyond the age of 75 is at the discretion of the patient and the physician. So I will tell you, people are, taking better care of themselves. They're living healthy lives. They're very active. And so we're seeing a lot of people who are getting screening done at the age of 76, at 80, because they're actually doing very well. And so the American College of Gastroenterology and all of the gastrointestinal societies that we follow in terms of guidelines for training and for treatment and evaluation, indicate that between 75 and 85, it's really at the discretion of the physician and the patient. So if you have a patient who is a very active 75, 76-year-old, and their expected life expectancy, just based on what's happening with them, is going to be over the next 10 years, then yeah, we want to go ahead and get that person screened, because we don't want them at 83, 84 developing colon cancer. After the age of 85, screening is absolutely not recommended at all. So once you're over 85, you're now considered beyond the screening age totally. And there's no talk of discretion. And so above 85, we would only do colonoscopies if somebody actually has a symptom of something. So they're actually having a massive hemorrhage, bleeding, or we did a scan and we saw that there was something in the bowel. So there has to be a particular reason. So now this is no longer a screening test, it's a diagnostic test. I think we talked about this. So we talked about persons of African descent being diagnosed at earlier age. And so initially, actually, the guidelines initially were that screening began at the age of 50. However, I'd say maybe around 2015, between 2012 and 2015, what we were finding is that in persons of African descent at the age of 50, we were finding a significant amount of colon cancer or advanced polyps. And so the evidence was so overwhelming that all of the guidelines and the societies said, this completely, doesn't serve the need of why we do this test. If we're finding the cancers at 50, where we're supposed to start screening, then we're missing the boat. And so it was then recommended that Blacks and Hispanics initially, they were recommendations were changed for screening to begin at 45 in those persons. And then as more studies and more evaluation of patient cohorts came along, then they just made it a broad sweeping recommendation across all races that we should start screening at the age of 45. And so if you have a family history of colon cancer, you should speak with your doctor to find out when you should start getting screening. So just as a, anticipating a question that could be asked, for instance, if you have a sibling or a parent that was diagnosed with colon cancer at the age of 40, then you should start getting screened at the age of 30. So the recommendation is that you should begin screening 10 years prior to the age of diagnosis for your relative. So just some stuff that's out there, patient education stuff on colorectal cancer screening. We hear patients, ask the question, I'm healthy, why should I get screened? So for all of the reasons that we said, colorectal cancer screening is for healthy people. If we find a polyp, we remove it and prevent it from becoming a colorectal cancer. Diagnostic colonoscopy is not for healthy people. It's for somebody that's manifesting a symptom. No one in my family had colon cancer. And so again, the answer to that is don't be the first. So there's always someone that has to be the first, right? And so don't use that as a way to avoid getting a colonoscopy. So if you're of the age, you're at this particular milestone where it's recommended that you have this as a part of your preventative health maintenance, please do some form of colon cancer screening. I have no risk factors. It's the same thing. The biggest modifier risk factor for colorectal cancer is failure to get screened. Only men get colon cancer, but we've talked about that. Men and women are equally affected. And so how do you arrange to undergo colonoscopy? So you should give your doctor a call. Call your primary care physician and ask them if you're of age, absolutely no symptoms, and say, hey, I'm of age, I have family history, I'd like to be referred or to a gastroenterologist. Or you can self-refer yourself. But it's always best to partner with your primary care physician because you want to make sure that they are involved. They're the person they're like the gatekeeper. So they're the one that's coordinating your care that needs to know everything about you. And so have that conversation. Gastroenterologists are specialists in the diseases of the digestive system. And we are the physicians that, not the only physicians, but this is the key part of our training in terms of performing our colonoscopies. So studies have shown that gastroenterologists are more likely to provide you with an examination of the complete colon and rectum, an examination that detects any polyps or cancer that is present, and an exam that is comfortable. Thank you. And that concludes my presentation, and I will be happy to take any questions from the audience.
Thank you, Dr. Moxey. As Dr. Moxey said, if you have any questions, you can either open your mic or you can put them in the chat and we will read them out loud. We do have one, let me see. Dr. Shea said, hi, Dr. Moxey, thanks for them great informative talk. Thank you from the Cancer Society for your contribution. Recent trend, more younger persons having colon cancer. Can you comment on that?
Yes. So I don't know that we know exactly why that's happening. I think a lot of it may be, I would sum it up to genetic and inheritance risk. Some of it also because when we talk about some of the risk factors, we talk about the sedentary lifestyle, we talk about the obesity, also putting patients at increased risk. And so I think that it's a multiplicity of those factors that's likely contributing. But they're not, at least in this particular population that I'm aware of, any definitive studies that indicate or say why we're seeing such an increased incidence of colon cancer in the Bahamas. And when we look at it, as I would have indicated previously, our statistics are analogous to statistics that are being seen essentially in most countries. And so we are analogous to the US, where, where most of in the US, this colon cancer also represents the third most common cancer um, in that particular population as well.
Okay, somebody's asking the difference between a cyst and a polyp.
Totally different. We don't see cysts in the colon. You may see cysts in other organs. You may see cysts in the ovaries. You may see cysts in the kidneys. You may see cysts in the liver. So cysts, the way that I explain it to patients, think of if you get like burned and your skin kind of puffs up, and then if you pop it, you have like a liquid that kind of comes out of it. That's analogous to like a cyst. Or think of a balloon that's like fluid filled. And so the balloon itself is, that thin layer, and on the inside is really a fluid collection, and it's only being held by that balloon that's kind of been blown up. And if you were to pop that water balloon, you're going to have the water that's going to come out. A polyp, it's not fluid at all. There's no liquid involved. It's completely a tissue. I guess the best way to describe it is really a pimple or like a wart that's kind of forming from the lining of the colon.
Okay, another question. Are there different types of colon cancer, and is there one that's more aggressive than the other?
Not different types of colon cancer, but depending on your stage, then that's going to determine how aggressive it is. And so staging is important, whether or not lymph nodes are involved and whether or not there's distant metastasis. If there's distant metastasis, for those patients, meaning when you say distant metastasis, it means that the cancer is now involving another organ. At that stage, it's not curative. What we can do in most cases, unless there's, say, a single lesion in the liver, that maybe there can be a resection that's done. But if the liver is studded, if there are multiple lesions throughout the entire liver, multiple lesions throughout the lung, it's going to make it virtually impossible to be able to get all of those lesions. And so good treatment can actually put the disease in remission and could give you increased length of survival, but it will not be curative at that point. If you have, say, a stage 2 or stage 3, where the cancer involves the lymph node, that's an opportunity for that cancer to be curative. But that's going to require you to do, in addition to you actually having the surgery, having the recommended chemotherapy, and maybe radiation that the physician is going to recommend be done.
Okay, somebody's asking what is the approximate cost for the various examinations or screenings? I guess colonoscopy
So
versus
I'm not sure what the stool test costs, the FIT test. However, if you are enrolled with NHI, that's actually covered on a yearly basis with your NHI physician in terms of lab work that can be done. I don't know what the cost is if you were to just go to the lab and you want to just do a self-pay rate. But I would imagine, if I had to take a guess, it's not going to be a test that's going to be more than say $50 to have done. The colonoscopy, on the other hand, is a more expensive test. It's the gold standard, but it costs more. And so if you're completely out of pocket, right now, actually, all of the gastroenterologists, and there are like 5 of us that are on island. This is colon cancer month time. We're all offering patients for screenings, colonoscopies to be done at significantly reduced rates. I think the rates are maybe they're all somewhere between $1,500 to $2,000, when ordinarily this test can cost $3,000 plus. And that includes facility fees. So of course you go to a facility, that facility is providing the equipment, they're providing the medications. You have an anesthesiologist who's providing the anesthesia, sedation, as well as your complete monitoring during the test. And then you have the gastroenterologist that's actually doing the procedure. So really getting that 3-in-1 done for under $2,000 is a steal. If you have insurance, all of the providers, I think, to my knowledge, I know this is something that we kind of agree that we do. Physicians and the facilities have been waiving. Some of the facilities, I should say, not all, have been waiving the co-pays associated. I know the physicians themselves and the anesthesiologists waive the co-pays. Patients would just be responsible for their deductibles. And so if you are an insured patient, you want to understand what are your benefits. And so certainly you can talk with your doctor, your primary care physician, you can see the gastroenterologist, they can send and request that information from your insurance company to determine what you qualify for. But nonetheless, if you don't have insurance, this is the time to kind of get that screening and stuff done.
Okay. So somebody else is asking, if you suffer from hemorrhoids and sometimes have slight bleeding, but otherwise healthy, regular stools, is there any reason for concern?
Well, yes, while hemorrhoids can be the most common cause for bleeding, you should not self-diagnose and say, I'm bleeding because I have hemorrhoids, because there could be something else happening in the colon. And so if you're bleeding for any reason, you should be evaluated to determine why you're actually having that bleeding. And so my recommendation is that you go in, you get an evaluation, and you make sure that the physician, gets a colonoscopy done. Where when I did my training at Cleveland Clinic, if you were 18 and you came and you said you had rectal bleeding, you had a colonoscopy. And I take that same practice here. That's how I was trained, and that's how I practice. And so once I would have cleared you and you would have had that done, and certainly, we're now able to see that you're no longer bleeding, then we can determine what the reason is, and certainly we're able to determine that the reason you're bleeding is not because of something that is malignant or something that's worrisome. Then that clears you. And so I always say, get that reassurance, do the proper test to make sure. Don't just assume that it's because of hemorrhoids.
Did you cover whether or not colonoscopies are covered under NHI?
Colonoscopies are not covered under the NHI. Another thing too, they're not. If you do not have, say you don't have medical insurance and you see an NHI physician, or you see any of the physicians at the public clinics throughout the Bahamas, and if the physician has done the screen, so they're not gonna, if this has done the stool test, if the stool test shows blood, they can refer you in to the gastroenterology clinic at PMH. I'm one of the consultants there, as well as two other gastroenterologists. We can evaluate you. You can have a colonoscopy done at PMH. It is not completely free there either. I think they charge about $500. But you can have a colonoscopy done at PMH. The wait is a little bit longer, as you know, in terms of trying to get things done just within our public health system, but the service is available. So, and if you are completely indigent and you're not able to even afford what the hospital charges for that service, if you speak with somebody in social services, and if they deem that you certainly are at the point where you don't have the capacity, they will, they can give you the allowance to actually have it done at no cost. For persons who are over the age of 65, the service is going to be free for a patient who's accessing the public service and they're over the age of 65. The government will cover that for you at 100%. So there are options available.
That's good to know. Somebody mentioned I had a family member who was very physically active, not sedentary, developed unprovoked blood clots towards the lungs. And he's discovered it after he passed out and needed evacuation, blood thinners, etc. He was treated successfully, but it was mentioned that there was a study that unprovoked clots are associated with colon cancer risk. Have you seen this in your practice?
Unprovoked clots are associated with any malignancy. It's not unique. It's not just colon cancer. So when we see somebody who has, we call a deep venous thrombosis, and there's no clear explanation, there was no trauma to the leg, they didn't give us a history of any prolonged travel anywhere, they are not on birth control, so there's nothing, they don't have any protein deficiencies that would put them at risk for developing clots. Anything that we can't explain that's considered unprovoked, that can be a sign of an underlying malignancy, period, not just colon cancer. And so certainly when we see that, it causes us to then start a workup that would look for cancer. And that could be breast cancer, prostate cancer, colon cancer, lung cancer, any cancer, any malignancy.
Okay. That covers all the questions in the chat. So I don't know if anyone else has any other questions which they would like to put in the chat or open your microphone and ask directly. Feel free to do so now. Portia, you have a question?
Yeah, I trying to open my mic.
We can hear you.
Oh, my mic was open. Lord,
Yes.
sorry. So I was testing to ask the good doctor if for but the fact that you're over the age of 50 and had not had a colonoscopy done before, would you suggest still being screened? I think you were mentioning seeing your regular doctor prior to having one done. There's no problems, no issues, no blood in the stools, no problems with passing, that sort of thing. But for being over age 50 and a former cancer patient, would you suggest to that person that they still go ahead and be screened to have a colonoscopy done?
So you said two things. One that kind of jumped out at me. So one, if you had absolutely no symptoms of anything and you're at the screening age, most definitely you should get screened for colon cancer. That's the take home message of the talk this evening. Once you are of the age, regardless of symptoms or not, screening does not require you to have symptoms. Screening is because you are now at that stage in life where this now becomes a part of your preventative health maintenance. The same reason you would go to the doctor and now you would get a mammogram done. Once you at the age of 40, you get a pap smear done at a particular age. You get screened for your cholesterol at certain ages. So at certain ages, for preventative health, we begin screening. And so 45 is now the new screening age where you should start to get, get one of the screenings done, with colonoscopy being the gold standard. If you have a malignancy, as you indicated, you said something about somebody having a history of cancer. Well, it depends on the type of cancer that you have. You are no longer considered average risk. You now have up to the high risk, especially if you've had endometrial cancer or ovarian cancer, any of the gynecologic malignancies, breast cancer. So persons who would have had breast cancer, they are referred as soon as they're done with their training, with their treatment for breast cancer. They are referred immediately to the gastroenterologist for colonoscopy. As a matter of fact, they're not screened even with the stool test. The recommendation is that they proceed directly to colonoscopy. they have a colonoscopy, and not only do they get the colonoscopy because of that history or that diagnosis of the cancer, they now also fall into the category where they're required to do a colonoscopy every 5 years up until the age of 75 or 85 if it's at the discretion of the physician and the patient.
Somebody is asking, is an upper endoscopy used in any way to screen for colorectal cancer?
No. And so the reason for that is because the upper endoscopy, the scope, the length of the scope, it only can actually get as far as the beginning part of the small intestine. The scope is not long enough that it can extend down into the colon. And so an upper endoscopy is a test that we use if we're concerned about somebody who has recurrent heartburn that's not responding to medication, somebody who's having difficulty swallowing, somebody that may be having an abdominal pain or even an anemia because you can have cancer of the stomach. Somebody who is, every time they eat, they're bringing stuff up. So they're not able to kind of keep down food. An upper scope is done for those patients. And as I indicated, the scope only gets to the beginning part of the small intestine. So when we think of our gastrointestinal tract, and we think about, we have the small intestine or the small bowel, and then you have the large intestine or large bowel. The small intestine is about 20 feet long. So if we were to take it out of your abdominal cavity and stretch it out, it's about 20 feet in length. The colon is about 5 feet in length. And so all of that's kind of like packed tight in there. And so the small bowel is one of those organs that we can't actually adequately evaluate the entirety of it with either an upper endoscopy or a colonoscopy. And in those patients, we use the capsule.
Okay. How often should you get screening if your initial screening was okay? Meaning, I guess, no polyps found.
So if no polyps were found, right? So it's a couple of things. If no polyps were found and you have absolutely no risk factors, meaning you don't have any family history of a first-degree relative with colon cancer, and you do not have or with a family history of adenomas, or you yourself don't have a personal history of a malignancy of another cancer, then we would say come back in maybe 7 to 10 years. If you have a family history of colon cancer in a first-degree relative, or if you yourself have had certain cancers in the past, then we're going to recommend that you have a repeat colonoscopy in 5 years, even if the colonoscopy is completely normal every time. You come back in 5 years. If you have polyps, the recommendation for when a repeat colonoscopy should be done, it depends on the amount of polyps and the type of polyps that are found. If the polyps that are found are, say, maybe 2 or 3, and they're completely benign, we will tell you to come back in 5 years. If you have a polyp that's found that, say, is a very high risk pre-malignant polyp, we may have you come back in a year or 2. If we go and we do a colonoscopy and we find that you have 10 polyps or 20 polyps, then we may see you in a year or 2 years. So it all depends on what you find, the type you find, and the amount that you find.
Okay, and somebody's asking, how can we reach you? But I'll direct them to the screen. It says,
yes, I left here. I just put it up on the screen.
Gastromed Associates. Go ahead.
Oh, I was gonna say it's on the screen, but I'm located on First Terrace and Collins Avenue. So that if you were leaving Doctor's Hospital and you were heading towards ZNS, it's actually the first corner on your left. So if you get to Colina and Atlantic Medical and ZNS, you've already passed my corner long time. So I'm very close to Doctors. And so it's, once you turn to the corner, it's the first building on the right. And the phone number is simple. If you want to give a pen, it's 605-2100. And then we have an email inbox, which is info@gastromadassociates.com. And I'll leave this information with the Cancer Society. So if you don't have any way of being able to write it down now, you can always contact them and they can provide you with the information.
Yes, we'd be happy to. And just on another note, for those of you who may or may not know, there's a Get Your Rare and Gear walk this month. I don't know the date. Erin, if you know the date, can you let us know, please?
Yes.
This year is a fundraiser for, I'll let Erin explain. She's probably more versed on it than I am.
Yes, Get Your Rare and Gear is a fun run walk. It's going to be on March 28th at Goodman's Bay, and it's geared towards colon cancer awareness. Funds from that event assist financially those persons who have been diagnosed with colon cancer and do not have medical insurance and need financial assistance for treatment or scans or medication. So yes, partake. I think the registration is $30 and it's going to be on March 28th at Goodman's Bay starting at 6 o'clock. So support that because, you know, it helps those who have been diagnosed with colon cancer.
Yeah,
The
so get your
registration-
rare and gear and get out there.
Yes, and registration is online. So you can go to Facebook to Get Your Rare and Gear and you can register online. We don't have any registration forms here at the Cancer Society. Everything is done online.
And I guess kind of as a closing comment, we have somebody shared in the chat that information shared tonight is so important on all levels, and healthcare professionals need to continue to share this message of prevention and what is available for therapy and management if needed. And thank you, Dr. Moxey and the Cancer Society for hosting this session. And I would like to also at this point say a special thank you to Dr. Moxey for sharing with us. Yes, very important messaging, and we cannot overemphasize the need for screening. As Dr. Moxey said, it's one of the cancers that's very treatable, and so the only way you can get to having, you know, not have to deal with all the other stuff is get your screening, get those polyps taken out before they become cancerous. So remember that. And for those of you who may want to share this message, the video will be available on our website. So you can either watch it or share it with other people, direct them to watch it, get good information and how to deal with things when they come. Dr. Moxey, I did just have one more question. Do you need a prescription for the FIT test, or can you just walk into a pharmacy or somewhere and request it?
You need to have you would need to have a prescription from your physician.
Oh, okay.
Yeah.
Okay.
They would just like any lab, it's a lab test. So
Oh,
you
okay.
need to have the physician write up a lab form for you to have the test done.
Okay. All right, thank you. And once again, thank you so much for sharing with us this evening. We really appreciate your taking the time out. I know you have an extremely busy schedule, so carving this hour and a half out for us is really special, and we appreciate that.
Certainly my
So-
pleasure.
Yeah, so I think there aren't any more questions. And if not, then we thank everybody for joining us tonight. And a reminder, if you can, to please go to the register for the Get Your Rare and Gear walk, support that very important fundraiser, and share the message. So until next week, we say thank you to all of you for joining us, and we hope to see you next month. Hope to see all of you again next month. So everybody stay safe and have a good evening. Good night.
Recording stopped.
Good night.
Good night, everyone.